It is my great pleasure to introduce our speaker, Dr. Julia Sacher today. Dr. Sacher is a professor of cognitive neuroendocrinology in the medical faculty of the University Clinic of Leipzig and the Max Planck Institute for Human Brain Sciences. She is also the director of the Leipzig Center of Female Health and Gender Medicine and a faculty member of Max Planck School of Cognition, the International Max Planck Research School of Cognitive Neuroimaging, and the Berlin School of Mind and Brain. Dr. Sacher is a distinguished university scholar and has held several prestigious awards and fellowships, such as Alexander von Humboldt Fellowship and the Brain Behavior Young Investigator Award, the CNP Felsen Award, and Branko Weiss Fellowship at the Society in Science, Zurich, Switzerland. Dr. Sacher's work advocates precision imaging for hormonal transitions like menstrual cycle, pregnancy, and the menopause, and encourages the integration of sex and gender-based analysis in neuroscience to uplift mental health for both women and men. And please join me in welcoming Dr. Julia Sacher. And one quick note, feel free to type your questions into Q&A box at any time during the talk, and we will address them at the end of the talk during the Q&A session. Thank you, and please take the stage.
Well, thank you so much for this kind introduction and really for the opportunity to speak today. It truly is a privilege to be collaborating with the Women's Brain Health Initiative, now more than ever, I feel. I'm going to start my presentation with the World Health Organization's criteria for biological sex and the social construct gender, as addressing and implementing those in medical research will be essential for making meaningful progress in personalized medicine. And this is particularly important for brain and mental health. If you look at the sex differences in prevalence in mental disorders at the bottom of the slide, this is not new. I'm sure everybody on this call is familiar with those. These numbers have been known for decades, yet women are still widely underrepresented in medical research and in medical trials. Why is this relevant to all of us, though? Because these sex and gender-specific differences in diseases can point us to underlying pathophysiology that we still know really, really little about. The hormonal transition periods are sometimes really harnessed for a period of risk and for understanding. I think this research is growing, but they're still very rarely seen as opportunities of positive change and as an opportunity for timely intervention, even though we know that ovarian hormones are among the most powerful modulators of neuroplasticity. And then finally, if our ultimate goal is really intersectionality, we need to learn more about sex and gender. And while this, of course, goes far beyond sex and gender, both of those constructs are vital components. And I feel it's just like the necessary first stepping stone that we have to take at some point to approach this ultimate goal of intersectionality. And so today I'll introduce my three-pronged approach towards these goals. I use neurochemical imaging, so mostly PET, positron emission tomography, to really get to the neurobiological mechanisms underlying sex differences with the goal to really design sex-specific interventions. Then the application of dance sampling, a field that Emily and her team have done seminal work in. We are also applying these methods to characterize individual hormonal patterns and trajectories of brain architecture to learn more about general mechanisms of neuroplasticity. And finally, I try to really build from scratch gender and sex sensitive cohorts to really start building those interdisciplinary large data sets that are at least a little more inclusive than the previous that we have had available for some time now. But coming to the specific work of my group, we aim to explore how hormones impact our brain and our behavior, how they interact with metabolic risk and psychosocial stress in the immune system. And one way of doing this is really honing in at hormonal transition periods as vulnerability models for depression. Again, in this call, I'm sure this is not news to anybody. 2 to 3 times as many women as men suffer from a depressive illness, which is really the leading cause of disability worldwide. And while this is one of the most robust epidemiological findings we have, independent of cultural background, we still know relatively little about the underlying mechanisms. So if we plot depressive risk, which you can see here in blue across the female lifespan, and we also plot one of the most important ovarian hormones, estrogen, at first look, those plots look very similar. And one might conclude even that the higher the estradiol levels, the higher the risk. But at second glance, it becomes clear that it's more complicated than that. And it's really not about the absolute values, but rather the fluctuations of endogenous estradiol across the female's own mean that seem to be associated with this heightened risk of depression. And of course, we know from the clinic that hormonal transition periods, such as puberty, postpartum, or perimenopause, are typically associated with exacerbation of psychiatric risk, and also many new onset cases occur during these times. And I'll start with the most dramatic, really, the immediate postpartum period, because with the loss of the placenta, estradiol levels go down 500 to 1,000-fold. And this change happens within a couple of hours sometimes. And the majority of new mothers do experience some symptoms of postpartum blues. So symptoms like crying, irritability, restlessness, anxiety, and fortunately, for most women, this phenomenon only lasts a couple of hours, sometimes a couple of days. And I don't want to pathologize, welcoming a child into this world and all the intense emotions that are associated with that are, I think, even necessary to experience during this period. But severe symptoms of depressed mood might not be necessary and can actually be a very powerful predictor of future postpartum depression. And this is the full-blown clinical disorder. It affects up to 15% of mothers. It's the most common complication of childbearing, and it is still really, really hard to get adequate treatment and diagnosis in time. And I don't want to be pitching diseases against each other, but even though I've done work in this field, I was really surprised when the CDC released a statement saying that there's more women who suffer from PPD and related illnesses in a year than the combined number of new cases for men and women to suffer from tuberculosis, MS, Parkinson's, Alzheimer's, lupus, and epilepsy. So I thought that that was pretty impressive in a very negative way, and that we still know very little about the neurobiology of this. And that was far before brexanolone, right? And I mean, to some extent, there's still much to be learned. But I think that was 15 years ago, we started looking at this target, this enzyme, MAO-A, monoamine oxidase A, because there was really solid data from cell lines and also in rodents showing an inverse relationship of this enzyme with estradiol. So if estrogen levels go up, MAO-A levels go down, and vice versa. And this enzyme breaks down monoamines, so serotonin, dopamine, noradrenaline. So it seemed particularly relevant for us to understand, well, is this enzyme changing in the postpartum period? Could that have a role in postpartum blues? And to look into this, into the living female brain, we use positron emission tomography, so PET. Which means we inject a radio-labeled tracer, and this tracer then displaces the endogenous ligand from the receptor or from whatever site it's binding to, because it has really, really higher affinity. In this way, you can label whatever target you want, a receptor or an enzyme, like MAO-A in our case. And then you acquire a scan. What looks really scary, like a Hannibal Lecter movie, is actually quite comfortable. You have a silicone mask, so you can actually take a little nap in the scanner. It's very quiet compared to MRI. And we collect counts and build time activity curves over 90 minutes. And at the end, you have one number. And so this is what I love about this technique. It gives you one actual number of very specific binding. But of course, it is quite invasive. And even though the levels are low, you are dealing with radioactive exposure. And in somebody who's just given birth, we were really scared that they would not be interested in participating in that intensive protocol. Because also for this radio tracer, you need an arterial line. You can't get away with a reference region. So it's quite intense. But we had a great interdisciplinary team. Everybody was very enthusiastic, and our participants were wonderful. And some of them actually told me that after delivery, an arterial line was nothing. And they really enjoyed the nap time in the scanner as well. So I think really how you build this kind of protocol and how you go about it then actually opens up opportunities to do very, very cool research that for decades people have told you this is impossible. And I think in this case it was really worth it because what we found was not just a significant increase of MAOA in the brains of women who had just given birth, but a 40% increase, which in terms of PET is insane. Like it's a really, really big change. And we saw that in every woman that we scanned compared to women who had either never or not recently given birth. And so based on these data, we built this conceptual neurobiological model where we think what's happening is that estrogen levels drop significantly, MAOA levels go up, and then this loss of monoamines, this loss of serotonin, dopamine, noradrenaline, that is so dramatic may lead to these mood symptoms. And one, additional anecdotal piece of evidence is that clinically postpartum blues is most severe on day 5. And this is actually when we saw the biggest peaks in our MAOA data. So the timeline nicely fit the clinical data. And these are data from an additional follow-up study. So now you're looking at patients in red. And these are patients who develop postpartum depression in the first year after giving birth. And in gray, you see controls. So women who also just gave birth, and they were actually matched for postpartum week, but they did not develop the disorder. And you also see MAOA levels still significantly increased throughout the female brain. But you also see quite a significant overlap between those two groups. And I think that's important if we're thinking about offering prevention strategies and intervention strategies, because there's very, very little in terms of different possibilities that a woman can really go to, right? If they go to their psychiatrist. In a really severe case, a strong family history and somebody who might have had an episode before, a reversible MAOA inhibitor might really be a great choice if the SSRI fails to help. But for someone who's just really concerned because they might have a heightened risk, but they have not experienced an episode before, lifestyle factors to lower MAOA activity might be much more attractive. And actually last year, so a long time after the first study was published, a nutraceutical, so a dietary supplement based on the MAOA work became commercially available. It's based on a blueberry extract, and it helps bring MAOA levels down. And it actually was quite effective compared to placebo. And I think it's the first nutraceutical. And women can continue breastfeeding, which of course in this cohort, in this population is often very, very important. And so in the interest of time, I'm going to move on to the second line of work, but I'm happy to dive into questions regarding the postpartum work at the end of this talk. But I now want to focus on these individual trajectories and the dense sampling methods that we have now brought to female neuroscience. And how this matters, to understanding the female brain in health, but also in disorders, and particularly in disorders that are tied to the menstrual cycle, such as premenstrual dysphoric disorder. An illness that just relatively recently has been added to the DSM-5, to our catalog of psychiatric diseases. And it may not seem like much in the beginning, right? It's just 2 to 3 days of symptoms before menstruation, but the symptoms match a full depressive episode in severity. And if you actually calculate it throughout the reproductive phase, if you don't take any oral contraceptives and you go through this every month, it can add up to 8 years of symptoms. And there is a subgroup of women who suffer from severe suicidal ideation in their symptoms as well. So it's really, really important to offer some opportunities to prevent and to treat this disease to the affected women. And of course, in an illness that is so clearly tied to the menstrual cycle, for a long time, it was assumed that there's some abnormality in ovarian hormones that had to cause this disease. But several groups have looked into this, and there was no clear association between any hormonal abnormalities. But what we know from clinical evidence is that SSRIs, serotonin reuptake inhibitors, work really, really well and very, very fast in these patients. And so this really led us to conceptualize this hypothesis about the serotonin transporter as a gatekeeper and the main target for the SSRIs to have a central role in this pathology. And so we decided to take a look again using PET C11-DASP, which is a specific ligand to visualize and quantify the serotonin transporter to see, well, does this change in women who are affected by PMDD, and does it change in health, and how do healthy women compare to patients? So we assessed women once periovulatory, once during the premenstrual phases, and so they underwent two PET scans, which is quite at the edge of what you can do in the reproductive years, but it was just below the threshold. And we calculated serotonin transporter binding in several cortical, but mostly subcortical region. And our main interest here was the midbrain, because you can see in the top row here of the PET image, this is really where the brain grows, the midbrain lights up. This is where we have the highest expression of the serotonin transporter. And what we found was an increase in serotonin transporter availability in patients from periovulatory to premenstrual, so just within 12 to 14 days, which was really surprising because for the longest time, at least I still learned in medical school, the serotonin transporter was a trait, and that, there's a genetic component to it, but then it may go down like 10% with every decade that you're aging. You're kind of stuck with a certain density. And so this, there is some seasonal work that suggested that it might not be that easy, but more complex. But this, within 2 weeks, this dramatic change, I think really challenges this assumption. And I think what's clinically, of course, more important, it really gives neurobiological evidence for luteal dosing of SSRIs. And that dramatically changes the quality of life of many, many patients. And it also opens up avenues towards non-pharmacological strategies to bring down serotonin transporter density. You can think about bright light therapy or 5-hydroxytryptophan, so also a dietary like serotonergic precursor that you could look into. Beyond really this clinical application though, and it was driven by this clinical work, when I did the research and I dove into the literature, I saw how little information was available regarding the healthy female brain during these age ranges. And this is really how we started. It was actually based on missing literature for a graduate student thesis, that we started a pilot study with one participant, 32 scans across 4 menstrual cycles, and meticulous menstrual cycle monitoring. So we took saliva, urine, blood. You can see at the bottom a vaginal ultrasound, so really folliculometries to measure the follicle, get ovulation exactly right. And I think at the very end, those are real data. So the green, the red, and the black lines already showcase how big the within variability of one single subject is. The estradiol peak during ovulation in the second cycle is nearly twice as big as the precedent cycle. So I think this really, I mean, anecdotally, but still clearly sends the signal that we cannot do cross-sectional assessments of these phenomena. It just doesn't do it justice. What we also found was that the hippocampus, a brain region important to memory and, of course, emotion regulation, but also really rich in ovarian hormone receptors, really dynamically fluctuated with the endogenous estradiol levels across the menstrual cycle. That was true for both white and gray matter, but of course, just a single case, right? So it was very challenging to get this published, but another graduate student, Rachel Cito, did this, like she took on this horrendous task of increasing the sample size and getting more than, I think, 40 participants in total for 6 longitudinal assessments across the menstrual cycle into a high field MRI. So now we're looking at the left side of the slide at a 7 Tesla scan. You can see a beautiful hippocampus. You can actually segment subfields, which to us was super important because those are all functionally very different and they fluctuate differently with different ovarian hormone patterns. And Emily was lovely enough to highlight this work in her editorial and opinion piece. So that was, of course, also really great for the student and for all of us to get this recognition that this was actually not a niche project, right? That this was not just a niche thingy for PMDD and that was a side project, but that actually had really cool implications for neuroscience as a whole. Which of course gave us a lot of enthusiasm to pour into building sex and gender sensitive large cohort studies, which is the final part of my talk. What you can see here is celebration of the peaceful revolution in Leipzig. It's really the city that brought down with the peaceful prayers and the peaceful marches. It initiated the bringing down the German wall. And so to have these people be so open and participate in a population-based study where so much data is individual data is collected. We had many discussions building this cohort, if that was even possible, but it was. It's more than 10,000 people from the age of 20 to 80. So it covers all the organs and it looks at population and civilization associated diseases like dementia, depression, diabetes. And the part that I'm going to show you in this final part of my talk is going to be from the neuroimaging cohort, which is 10,000 healthy participants. And you're going to look at MRIs. I'm not going to repeat too much of what I think Rachel Buckley already spoke about. Dementia rates and how women are affected, and that 2 of 3 patients with Alzheimer's today are in fact women. I'm going to try and focus on sex differences and the role of obesity in this context. Because we know that metabolic abnormalities and the first indicators of neurodegenerative processes begin 2 to 3 decades before the clinical symptoms really occur. So this is a fantastic opportunity to see if we cannot prevent, at least delay symptoms. I'm sure most of you are familiar with these kind of scans. This is a structural MRI image from a patient with medial temporal atrophy, a process that we often see in patients with dementia. But what you might not be as familiar with is looking at these kind of images. It's also an MRI, but of subcutaneous and visceral adipose fat. The visceral fat is in red, the subcutaneous is in blue. Why are we doing this? And why, if we're looking at obesity, we're not just looking at BMI. It's much easier to calculate. And this is my slide to make the claim that this segmentation is really important. You see 2 males, 2 females, both of similar age and similar BMI. but the ratios of visceral or organ fat to subcutaneous fat are really, really different. And that might indicate that these individuals will have dramatically different aging trajectories, including brain aging trajectories, because we know that this organ fat not only promotes insulin resistant and promotes the systemic low-grade inflammation, but it can also tip your HPA axis, and more importantly, because we mostly care about the brain, it is a risk for brain aging and neuronal damage. So all the things you don't want to have, microstructural brain tissue damage, white matter lesions, decreased hippocampal volumes and thinning in prefrontal areas, they all have been associated with obesity, but not a lot of people have looked at the sex differences. So again, Rachel, the hero graduate student in the last couple of years, she looked at cortical thickness, she looked at volume and cortical surface area in these thousands of scans we had. And she and the team, they segmented the bellies of all these participants. And what you can see here in the graph is not surprising. There is different visceral fat accumulation rates across the lifespan, right, between males and females. Males tend to accumulate visceral fat a little earlier, but the problem in female visceral fat is that there's this accumulation point at the age of 47, which pretty perfectly hits the onset of perimenopause. Now we calculated this memory network structure, which you can see here in the bottom. And so other groups have shown this inverse association and maybe harmful effect of visceral fat and brain structural integrity. What we have shown for the first time is the sex difference. And here it might actually seem that females are a little bit protected. The curve is not as steep. So then we looked at endogenous estradiol and we thought, well, maybe estradiol is protecting the female brains from this harmful effect of visceral fat. And we ran a moderation analysis, and indeed, in females, this is what we found. And then we ran a post hoc analysis of this, relatively small sample. And we're no longer talking about 1,000, but I think it's 88 in the perimenopausal age, where we looked at the females that we had in this age range, and we matched for age and for the visceral fat actually, but the estradiol actually distinguished between the females who had a more conserved memory network and who had better memory performance compared to the women who were in the same age range, same visceral fat, but had lower endogenous estradiol levels. So maybe summarizing these life data, to us, it really highlighted the perimenopausal onset, right? And how important this is for neurology and how this is a neurological transformation state. But that you really need to look at the entire body, of course, to be able to use this information to maybe help with pinpoint this trajectory in a beneficial way, right? And this, of course, was really interesting work, but it only put sex as a discovery variable. We haven't talked about gender yet at all. And so this is one of the current projects we have where we're trying to include gender as well. I'm sure most of the people here know and are familiar with the work of Vera Regis-Sarkosek, a pioneer in sex and gender medicine, who originally trained as a cardiologist and who found sex and gender to have opposing effects on cognitive performance in patients with cardiovascular risk. So in the Berlin long-term observation of vascular events, another student of mine, Emily, is now applying this Genesis Praxi, this gender composite score developed by Louis Pilote. And she will see if she can actually replicate some of these, I think, very, very interesting findings of the Regis-Sarkosek group. But I think we also need to really be self-critical in this. I think there's some publication bias here as well. We have those large databases, and we it's an important step to look at sex stratified analyses in these databases, but we also know that high impact journals really like large, impressive data sets, when the real work is really the acquisition of this data. And most of the currently established large biobanks still fall short on, increasing cultural sensitivity and diversity in neuroimaging studies. And I mean, it's clear why. This is incredibly cost intensive. It is very hard. You need to start so early. So it's not feasible for graduate projects, right? But it is crucial to have community engagement very, very early, to be open to reviewing and revising your inclusion and exclusion criteria several times, and to really change your recruitment and screening strategies based on those recommendations if we want to make progress towards a more inclusive neuroscience. And this is the last example we currently have from where we try to go beyond correlation, but at least approach causation in a population that is incredibly vulnerable and that's typically understudied. So it's transgender individuals, and we follow the long-term effects on different organ systems, including brain and behavior, of gender-affirming hormone treatment in these individuals, because there's still very, very little knowledge. But of course, it's also a very interesting model to look at underlying mechanisms. Okay, what do these hormones do in the opposite sex and in these different organ systems? And so I'm gonna end this presentation with this big problem that we're still facing, really this knowledge gap, this missing data gap. Emily has seen me talk about this before, but unfortunately it hasn't changed with most of the presentation. The first question I get, and that also my students get, are, well, what about the men? And I do care about the men. And I also don't want to downplay the significant data gaps and the stigma we're facing with male health, particularly male mental health. 3 out of 4 suicide victims are males. And I can really recommend this documentary, Beyond Men and Masculinity, where there's really this idea of that we have to be more open, discussing emotions that are uncomfortable in societies, such as shame and fear and anxiety, and provide peer support. And we're trying to do a little bit of this, including digital health measures. But really, the most important data gap that we are facing, and that is context relevant for us, it is not men, it does not concern males, it is the other 51% of the population. And Lisa Galea and her team really, really elegantly demonstrated how little has changed in the last decades. Only 4% of neuroscience papers looked at sex as a discovery variable. Psychiatry is doing a little better, but still not impressive at 13%. Given the huge numbers of female patients suffering from psychiatric and neurological disorders, this is a huge data gap, and time alone will not fix this problem. And so we need to do something about this. We need to change this, because it's a matter of justice and rights, of course, but also because it's crucial to producing excellent research, and even more because this knowledge is essential to be able to provide the best care for our patients. I'm sure most of you know that 80% of the drugs that are withdrawn from the market are withdrawn due to side effects reported by women. And these drugs, the majority of them have been developed in male animals, and they're still more often tested in male participants, but then prescribed to female patients. And lecanemab, the Alzheimer drug, right, is a really, really problematic recent example where the data supports a promising effect in male Caucasians, but is not equally supportive in females. But the majority of patients who will get this drug might be female. And so with this, those are this is our to-do list. We need to investigate sex and gender specific pathologies. Of course, ideally, there is more funding dedicated to this aim. We are focusing on women and investigate hormonal transition periods. That includes reproductive history, that includes hormone use. And then, of course, putting sex and gender as discovery variables. And with this, I am so happy to be collaborating with the Women's Brain Health Initiative. And one of the, very specific and concrete examples that the work that you guys do is, of course, the reproductive health history questionnaire that I think is really going to move the needle if it's included in, all our data acquisition efforts, because it's so important and vital information that has been neglected for such a long time. But now I want to thank all my incredibly supportive clinical partners in this Leipzig Center for Integrated Health for Women's Health and Gender Medicine. And it's really an honor to be working with these experts who emphasize sexual medicine as one of the core specialties in this clinic. And there's also a transgender clinic that in the current political climate, at least also in Europe, is not a given, but something that we constantly have to advocate for. And I also want to give a shout out to my super productive, very enthusiastic team of undergraduate, graduate, and postdoc students who, of course, are the ones who are doing most of this work. And it's really a privilege to be working with them. And thank you so much for giving me the opportunity to speak to you today. Really looking forward to your question. Thanks for your attention. And so how do I now choose?
Perfect. So much. Sorry, I'm saying something.
Well, Jaren, as you're maybe pulling up the questions, I'll just say something that I said before most people on this call, which is that Julia really represents, in my mind, the pinnacle of this combination between computational health and women's brain health. You are that rare scientist that can weave in and out of levels of inference with big data down to precision imaging and back again, sort of this reciprocal validation model in psychiatry where both of those sorts of data will inform one another, and you just do it so beautifully, and you're just the best person to work with. So science.
Well, thank you so much. But obviously, right, no single individual can do this, and I've been really, really lucky with the colleagues and the trainees that chose to work with me to be able to venture into different directions in this work. Thanks.
Yeah. Well, let's get to the questions because they're popping in.
Yes, right.
Maybe I can start. So Judy Pa asks, thank you for this wonderful talk. What do we know about the increase in suicidality with treatments for PPD, especially for SSRIs or other drug treatments?
Okay, so I mean, this is a little beyond my own expertise, but I'll try to answer. I think we don't have the data, really, the longitudinal data comparing this, because I think the problem is that we still have these obstacles in getting diagnosis and getting treatment, right? And then there is very little, I mean, at least in Europe, maybe it's better in the US with brexanolone now, but very little systematic assessment of who is getting offered what kind of treatment. And then again, there's such a taboo with suicidality, right? It's so incredibly hard for mothers to get mothers to speak about this. If you, at least in my studies, if we enrolled them, that was actually an obstacle in the first postpartum study. With the first round of protocol, we didn't get any strong clinical data. So then we thought, well, what's going on there? Is there a bias, right? Are we not reaching the sickest patients? But what we then understood is that when we gave them the typical questionnaires, including measures of suicidality, they would just not be open to answering them. But then there was some time after the scan when I had to put pressure on the artery after the draw of the arterial line. So then they were much more open to actually these kind of interviews. So we learned a lot during the study how we had to ask these questions, but to get into treatment effects, and I'm guessing Trudy is asking also about suicidality increases with the treatments. I don't think there is strong systematic data, but I might, if somebody else has more information, please feel free to correct me on this.
And I see Dr. Carmona on this call too, so maybe we
Okay.
can start a forum when we put this on the YouTube. Marta asks, thank you for this great talk. I would like to raise the topic of what to prioritize in menstrual cycle studies and cognitive processes, sample size or number of measurements. How do you decide a suitable design that satisfies statistical power requirements in sufficient depth into the different hormonal phases?
Yes, that's a great question, and one that we've grappled with for years. I'm sure you have too. I mean, we took a very pragmatic approach, right? We started with this very exploratory pilot data set, and we were very transparent in, sharing that this is not an a priori hypothesis, that really just exploratory. But then we learned a lot from that, and that's what we based our statistical power analysis on then, right? So then I think it depends on your research question, but a lot of the high dense sampling work has been done by you and us, and I think a couple of other groups. So I think you can build on this work now when you design your own study and might, be more interested in changes of cognition, that you just look at maybe the 3 or the 4 time periods where we see the most change or where we found the most change, and then start with this and go from there.
Sorry, and I was just typing this out, but maybe I'll just announce it. This is another plug maybe for keeping an eye peeled for our educational workshop at OHBM. Fingers crossed it gets accepted. But it's on quantitative neuroimaging and women's brain health across the lifespan, and we're really going to dig into some of these questions, like how do you design the right methodological approach based on the questions. This is led by Jaren, who's on this call, Amy Kusieski, Laura Pritchett. Julia is going to be one of the panelists. We have Winnie Orchard, Magdalena Martinez Garcia. It's sort of a who's who in this space, so across the lifespan. So if you happen to be in Brisbane, Australia, and maybe we'll try to record and disseminate some of those materials from the educational workshop as well. So okay, and Nicole asks, great presentation. On slide 49, I wonder how the impact of that during adolescence for girls is implicated in this relationship, especially since the data shows this trend starts at age 20, but adolescent girls have a rapid increase in VAT during occurring with puberty. I wonder how the VAT estradiol relationship changes over time, course of puberty, adulthood, pregnancy, midlife, menopausal transition into older adulthood.
Great question. And to be honest, I don't have the data. I don't know for sure. What I do know is that I have colleagues here in Leipzig who are specialists in childhood obesity. So they are currently trying to build this cohort to expand to childhood, including the MRI, but we haven't been able to get it approved yet. We're still in this process. What I know from my colleague throughout childhood and puberty is that she really has data showing that it's the early childhood that where this visceral obesity already seems to be a gatekeeper of how future trajectories go. However, I mean, with a grain of salt, because all of these studies do not focus on sex differences, right? Or on how adult hormonal transition periods still may be able to change that. I do think that, there's obviously a strong genetic component when it comes to obesity and when it comes to childhood obesity. They have very strong data linking digital and social media use with childhood obesity, and that being a predictor of lifespan trajectories. But I think there's a lot of work on sex differences and specifically female changes and puberty changes that hasn't been done yet.
Dr. Caitlin Castelletto at UCSF says, beautiful talk. Could you comment more deeply about the differences you are observing on how vascular risk may show opposing effects on brain health by sex?
Yes. So, I mean, this is really Vera Sakosek's work. And what she has shown is that female biological sex seems to have a positive effect, right? So the females actually did better than the males in the cognitive tasks. Cognitive performance was higher. But if they scored very highly on this gender proxy composite measure, which kind of gives you several questions of how much you identify as a woman in current society. So it might even, play a little bit into stereotype threats and, gender stereotypes. You actually do worse. So women and women gender had a negative effect on cognitive performance, whereas female biological actually had a positive effect.
And Joanne says, I'm at the initial stages of designing a research project. How can I ensure that the data collection will be sex and gender inclusive from an early stage? Is there anywhere I can find resources about setting up a sex and gender inclusive research project?
Yes, so I think that it's actually US colleagues who have developed this illustration that I've also included in my talk about the engagement of community, right? So I think it depends a little bit what the project is aiming at. If you want to look at the transgender related question, that might be a good resource. But I think it's also, I mean, you don't have to do everything all at once in every project, right? I think that often also scares researchers, particularly junior researchers, a little bit. If the menstrual cycle, has those big effects, like, I mean, how can you even conceptualize the study? So I think first, it depends on the question. I would go into the literature, see, is there any evidence of sex differences, of hormone effects? Take a look at the animal literature. Often, right, our colleagues, our basic scientist colleagues have done tremendous work, and it might be a couple of decades ago, but it's still very, very relevant. And then if you have, and then obtain pilot data. I mean, that's what we currently do. I do think it's okay to like lower the expectation a little bit. You don't have to get it perfectly right from the get-go. And then maybe collaboration. I mean, that's really a lot of the lines of work that we are now embarking on. We could never do this by ourselves, but because we're pulling data or we're focusing on one aspect of the question, and Wiebe in Copenhagen or Belinda in Austria, or like my friends in Toronto are looking at a different aspect, and then we are merging the data. I think that also really helps. And I think particularly in the Women's Brain Health Initiative, I mean, I've had tremendous support already, and I'm pretty new still, I think, to your community. Reach out to PIs who are doing the kind of work that you're planning on doing. I've very rarely encountered had a negative experience. Typically, people are very excited that somebody else is joining the cause.
Well said. Tamara Lewis Johnson has a really interesting question. This is an outstanding presentation. What is the evidence of PPD and PMDD in women who are on hormonal contraceptives? And what is the link to PPD to perimenopause and HRT?
Mm-hmm. Well, it's a tricky question because many of the study designs also grapple with this effect of a little bit of bias, right? Because often women, I mean, there's this Danish study, right, that has shown, and they have those fantastic databases of prescription rates. So they could, in a huge sample, link SSRI prescription with first-time hormonal contraceptive intake. But one criticism of the study was that there's probably a lot of women who take oral contraceptives, who avoid oral contraceptives because they did not tolerate them well. And it might have been because of mood symptoms, who will never actually, even in this kind of super elegant design, actually show up in the data, right? We also know, I think, from the PMDD field that most of the oral contraceptives are not a very powerful way to treat the symptoms, right? This is why the SSRIs even came into the picture. We know that if ovulation is completely suppressed, yes, then the symptoms typically go away. But most oral contraceptives don't completely suppress, right? I mean, they downregulate. And it is not really the ovarian hormone fluctuations that seem to drive the problem. So it might really be about the individual decrease in context with risk factors that you already have. I'm not sure if I've answered the question, though.
I think that was good, and I pointed her to some resources from Adrienne Beltz and others in this space. So I think we have time for at least one more, maybe both of the remaining two questions. Among all of these brilliant points, the variations in hippocampal morphometry with hormonal cycle was mind-blowing for me as I work on data sets from patients with focal drug-resistant epilepsy, where hippocampal sclerosis is a common etiology. Blood biomarkers and catamenial associations may not be routinely collected in these patients, but I would like to ask if any of participants happen to know of any data sets with these variables in epilepsy cohorts. Catamenial epilepsy.
Sorry, I personally do not know.
I'm thinking of
really interesting, and I need to think about it. If I come up with a colleague from neurology who actually does have a suggestion, I'll let you know.
There's Esther Bui. I think she's in Canada and she studies catamenial epilepsy. I'm not sure if she's been doing kind of hippocampal scanning, but she's somebody who you might reach out to more.
There's also the Human Connectome Project's Epilepsy Connectome Project. I don't know if they collected hormone levels, but that might be something to look into.
Summer's comment is sweet. Such an amazing talk. Best way to start my day. Thank you so much.
Thank you so much.
And maybe we'll close it out. There's one last one from Emma Gleave. Do we know of any additional hormonal interactions, such as histamine and estrogen levels, that could be influencing PMDD severity?
Yeah, again, a little beyond my immediate expertise. I do have some anecdotal data about this because I'm working in the clinic, and I do have some patients who on antihistamines actually but it's probably because of the sedation, right? The sedative effect. They feel a little more mellow. But I think, getting at the actual neurobiological mechanism of this question, I'm afraid I'll have to look it up.
Well, I think all of us echo Summer's sentiments. Julia, thank you so much for lending us your time and sharing your expertise with this incredible cohort behind the Women's Brain Health Initiative. And I'm your biggest fan, and we can't wait to join forces with you. But I'm just so glad that we could share your brilliance with everybody else. So just a reminder that Julia's talk will be up on our YouTube channel. So if you have friends and colleagues who should be blown away, please share it widely so her work can really continue to make waves. Not that you need an assist. You're already doing that on your own.
Thank you so much. That was such a great talk. Thank you.
Well, thank you so much for having me. And I can't wait for the reproductive health questionnaire to come out. I think that's really going to be a game changer. Yeah, and I'm excited to hear all about the future seminar series.
All right. Bye, everybody. Talk to you next month.
Bye-bye.